Hi, everybody. Welcome. Um, so let us continue with chapter 14 in abnormal psychology, okay? Into the really interesting area of disorders that are unique or not, well, yeah, it's probably fair to say unique, but particularly relevant to the elderly, okay? We will look at some of the major disorders that are relevant to the elderly, as well as touching upon some of the disorders we've already spoken about before, but as they relate to older individuals. Okay, so without further ado, let me call up my screen. And with that, let's start right here. Alrighty. So, chapter 14 is on neurocognitive disorders and disorders related to aging. So, we will first of all talk about some of the characteristics of the elderly that make them particularly vulnerable to certain disorders or disorders in general. Yeah. Um, then we'll talk about delirium. Alrighty. And a very common, more commonly found among the elderly. It can occur among middle-aged or middle older individuals, but far more something common among the elderly. Then we'll talk about the dementias, yeah, now referred to as major neurocognitive disorder, and then distinguish that from mild neurocognitive disorder. Okay, we'll touch on Alzheimer's in particular, and then we'll talk a little bit about depression as it's as it manifests itself in older individuals. Okay, when thinking about the elderly, yeah, and here we're talking about the population defined as those 65 and older. Yeah, and generally in the literature, that group is even divided into three subgroups, very typically. Yeah, the young elderly from 65 to 75, the middle elderly, yeah, or the mid elderly from 75 to 85, and then the older elderly from 85 onwards. Alrighty. And as a general, people can vary in terms of their behavioral, cognitive, emotional functioning along those three subgroups. Yeah, but there are certainly very typically events physically, situationally, emotionally, and behaviorally that tend to occur within each of those groups. Yeah, and I think if you think about family members or other people you know at work and other close acquaintances, you may see some distinctions across those three groups. Yeah. Um, Now, one of the things that's important to keep in mind when working with an elderly client or patient are the physical vulnerabilities, which are which clearly distinguish the elderly from the younger age groups. Yeah, there's a decrease in cell synthesis of proteins. Yeah, that's going to affect a number of areas of functioning, certainly things such as muscle mass development. Yeah, or decrease. You know and as a general matter, I don't think you lose muscle mass per se, but it just muscles do shrink in terms of their size. Yeah, but you never lose muscle mass per se. Okay, but certainly muscle size decreases in strength, capacity it changes, yeah, with age. A decrease in the immune system, yeah, and muscle, although I wrote here decrease in muscle mass, I think more accurately it's a decrease muscle mass in the overall size, but in terms of the actual physical cells there, let me correct myself, the overall size amount of space that the muscle takes certainly changes, yeah, but in terms of the actual muscle cells, they don't just disappear, yeah, but they certainly shrink in terms of with aging. Alrighty, so muscle mass does decrease. So um, just had to correct myself there. Bone density, increase in the proportion of body fat, very commonly. And all in combination, all of these things will lead to decrease in physical strength and mobility, agility, reaction time, and also an increase in physical illness. Yeah, which certainly has an impact on behavior and emotional functioning. We also have a decrease in sensory acuity. Yeah, in terms of vision and clearly with hearing, very common. We actually start seeing some of these things actually in middle age. Yeah, even starting with the with the people in the excuse me in their 30s. Yeah, with getting needing to get corrective lenses and so on. Yeah, we have a decrease in the weight and volume of the brain, and also significant changes in hormone levels. Yeah, across time. And there's also things to be said about psychological vulnerability. Yeah, very significant changes in terms of social support, relationships, and so on. Yeah, in terms of intellectual functioning, there are changes in terms of the ability to store new information, again, reaction time, and so on, both for visual and auditory stimuli, right? So the combination of all these physical vulnerabilities, increased physical vulnerabilities, increased psychological vulnerabilities, are going to have an impact on overall psychological functioning, as we'll see in our discussion that we'll have in right now. Um, let's first talk about delirium. Okay, what is delirium? Right. Some of the major characteristics of a delirious state, yeah, include extreme mental confusion. Yeah. So someone who's experiencing a delirium might wake up one morning and suddenly not know where they are, what time of day it is. Might even be confused with who's speaking with them. Might be having auditory hallucinations, maybe even visual hallucinations are not uncommon. Yeah, hearing, seeing things, might be experiencing odd physical sensations. Yeah, like one common physical tactile hallucination is electricity, static. Yeah, and with this kind of confusion, in terms of sensory stimuli and so on, will come a difficulty with focused attention. Okay. Others may have difficulty speaking. They may have difficulty with orientation in time and place, not necessarily person, but very typically time and place. Yeah. And it's also, you can kind of overall describe it as a difficulty as well of tuning out irrelevant stimuli. Yeah. So they might be affected by the light coming through the bedroom window, right? The squeaking of a door, someone enters, all that kind of stuff. Okay. Now, delirium usually has a very quick onset, yeah, very relatively instantaneously. Yeah. So someone may go to bed absolutely fine and then wake up the next morning in a delirious state. Alrighty. The duration can last for anywhere between hours to some days, but generally, delirious states tend to be brief. That said, they should be addressed immediately. Alrighty. Now, probably the most common cause of delirium is some reaction to a medication. Yeah, maybe a new medication, new combination of medications, new dosage, and so on. Yeah, and with the elderly, yeah, that is a common experience or psychological phenomenon. Yeah, having to deal with very typically more than one medication, often several medications. Yeah, with different dosages at different combinations at different times, and sometimes it may be what is prescribed, or it may be how, when you think about it with several medications, right, how they're consumed by the patient. Yeah, if certain medications could have needed to be taken on certain days at certain amounts, right? A half a pill versus a full pill. Sometimes those minor changes can bring on a state of delirium. Alrighty. But just getting back to how it may not be a function of what the patient did, it could be a function of new medication prescribed by the physician or dosage and so on. Okay. As we mentioned, the individual may experience hallucinations, certainly a lot of disturbances in their ability to organize information. Um, so they might confuse an alarm clock for a fire bell. So they hear the alarm clock, but they think it's something else. They have a hard time making sense of the information that they're taking in. And again, hallucinations. Yeah, feeling the bed has some kind of electrical charge. Yeah, literally experiencing that, this kind of tactile hallucinations. Okay. Um, uh, with During the course of the day, one may observe a dramatic slowing down, a decrease of these symptoms. That said, you don't let it lie. You still address it. Okay. The person may also demonstrate different fluctuations in restlessness and stupor, yeah, or lucidity or wakefulness. Yeah. Now, what I'd like us to do at this point, let me get out of this, is I'd like us to watch a video, which I think is a very good illustration of delirium. Yeah. And also how to kind of assess for this. Alrighty. So let me bring that up. And oops, here we go. Right here. Let me turn up the volume. Oh, very good. And that, here we go.
Okay, Mr. Stevens, I'm just going to give you a quick test here, all right? I'm going to touch your hand with this, and you tell me whether it feels sharp or dull.
Why am I here?
You're in the hospital. I said we're just going to give you a little quick test, okay? Does that feel sharp or dull?
Mary left yesterday.
Mr. Stevens, you're in the hospital with me, okay? We're just taking a quick look at you, and I just want to know whether this feels sharp or dull.
Oh, is that Mary?
Mr. Stevens, can you work with me for 1 second, please? Can you look, sir, can you look at me?
Where am I?
You're in the hospital, sir. I just told you that. All right? Can you look at me for a second?
No.
Mr. Stevens? Mr. Stevens, can you look at me for a second? Does that feel sharp or dull?
I just want Mary.
They're never going to think I did a complete neuro exam.
In an older person, inability to cooperate with the physical exam is a physical sign. It tells us the person has reduced attention.
You tell me.
Mr. Stevens, really quickly, sir.
You didn't tell me.
Just really quickly, does that feel sharp or dull?
Is that Mary?
Sir, can you look at me for 1 second? Just really quickly, sir. Can you, Mr. Stevens?
Reduced attention, particularly if it's sudden in onset and fluctuates through the day, suggests delirium. In a patient with delirium, there are a few things that you should and should not do. You should aim to confirm that delirium is present using the Inouye et al. Confusion assessment method. Find out how long they've been in their present confused or disorganized state. Find someone who knows them and ask them, when did this start or when were they last themselves? Establish the baseline. Are they normally cognitively intact, or do they have a history of dementia or memory problems? Clarify the fluctuation. Does this confusion seem to come and go throughout the day or night? Is this new? Examine for inattention. Can you count backward from 20 by twos? While they're doing this, tap a pen on the rail of the bed to distract them. If they can't do this, ask them to count from 1 to 10.
Okay, Mr. Stevens, I'm going to ask you to count backwards from 20 by twos. Okay, start at 20 and count down by 2.
20.
Okay.
18.
Mm-hmm.
16.
Yeah. And keep counting. Mr. Stevens?
I'm still looking for Mary.
Examine for altered level of consciousness. If they're anything but awake, alert and appropriate, i.e. agitated or somnolent, they have altered level of consciousness. Finally, check for disorganized thinking. Try a question like, what brought you to the emergency department today?
Mr. Stevens, I've got a couple questions for you. Sir, do you know why you're here today?
Where am I?
So you're in the hospital. Do you know what brought you in here today?
Where's Mary left?
And Mr. Stevens, we're going to try something a little different. Could you tell me what year you were born, sir?
Where's Mary?
The remainder of your physical exam should therefore be dedicated to trying to objectively determine abnormalities. Examples include not moving a limb spontaneously or prompted, guarding on the abdominal exam, fever or other abnormal vitals, skin rashes, ulcers, etc. What should you not do? You should not rely on subjective information from the patient, like, does this hurt, or is this sharp or dull? You should not argue with the patient. You should not assume that when you come back with your staff person in an hour, that they will be in the same state they are now. Because it is so distressing to patients and their families, knowing how to manage delirium can be one of the more satisfying experiences as a physician.
Okay, very good. That was a really excellent demonstration of what great dramatization of what delirium looks like, and also how to assess for it. Okay, and I think if we learned anything, you don't scream like a banshee at the patient. That doesn't help them one little bit. Alrighty, so when you suspect that kind of stuff going on, now you know a few tricks of trade, so to speak, in order to assess that. Yeah. Let's see. So let me get back to this presentation here. Okay. Okay. And the typical treatment is, well, certainly when you encounter someone like this, if they're not in a hospital, get them to a hospital so that they can be medically assessed. And, and it's often very readily, in most cases, it's readily treatment by another medication or changing the current medications, right? But certainly keeping an eye on the person physically in a facility prepared in case there's any elevation of the symptoms. Okay. Um, because untreated, it could lead to a coma or even death. Alrighty. So this is one of those things you just drop everything and don't get in a panic state, but then you calmly and quickly get them to a hospital. All right. It's like a stroke. If you see somebody with symptoms of a stroke, right? And we won't get into it for purposes of today's discussion. Yeah, but if it seems as though one half of their face seems to be a little droopy, or they have a hard time articulating, because actually, they may be having some hemiparesis, part of their face, which is not allowing them to express themselves orally, things of that sort. Yeah, you get to the person to the hospital, then right then and there. Alrighty. If it happens in the middle of a psychotherapy session, right then and there, you to get them to a hospital. Alrighty, let's talk about major neurocognitive disorder, which is uh, refers to dementia. Alrighty. Now, dementia occurs far more commonly in the elderly. Alrighty. But a thing that has to really be kept in mind is that dementia is a medical diagnosis. Okay. It is a mental disorder. It is not a part of normal aging. Alrighty. Now, certainly a part of normal aging are some decrements in cognitive functioning, which you may have learned in tests and measurements. Um, that we kind of touched on just a moment ago. Yeah, some impairment in terms of incorporating new information to memory, reaction time is slowed, right? Um, but that said, even though some of those things very typically occur as people get older, dementia is not a part of normal aging. It's a separate disorder. All right. That just typically more commonly occurs in the elderly, 65 and over. All right. In some rare cases, you can have some early onset dementia in individuals in their 50s, but that's far more rare. You won't run into that very often. Yeah. So a major neurocognitive disorder represents a profound decline or deterioration in mental functioning. Yeah. So it's really important to distinguish it from a normal aging or depression, as we'll talk about in a moment. Depression in an elderly person. Okay. Impairment tends to affect most notably memory. Usually, this is the first thing that's noticed in patients and in their family members. Thinking processes, logical reasoning, problem solving, and so on. Attention is also impaired, yeah, as well as judgment. In terms of how to, as I just touched on, yeah, related to thinking processes, solving problems. For example, if let's just say there's a little fire, the grease fire on the stove, the person just having a real difficulty figuring how do you handle this, right? If the grease kind of lights up on a pan, right? And it's not too high, right? You might just put a cover and just throw the cover over the pan, and then you smother the fire. Or if it's a little bigger, right, you might throw flour on the stove. Big old mess, but that's a way you might handle it, right? To smother out the flames. Someone who's suffering from dementia would have a hard time figuring out how to handle that kind of situation. I think you can throw flour on a grease fire on a stove. Correct me if I'm wrong on that. I don't think you make the place explode or anything when you do that. I think that typically will smother out the fire, but maybe I'm wrong. Alrighty. I don't think I may have some initial signs of dementia. Alrighty. Um, so what are some what are some common symptoms? Yeah. And, as I mentioned in an earlier chapter, yeah, schizophrenia is such a horrible disorder for someone to suffer through because it just affects so many areas of functioning. Yeah. Well, in a similar way, dementia does too. Yeah. Because it just affects so many of the things that we consider part of being an adult, right? To be a functioning adult. Here are some of the common symptoms of dementia. Aphasia, an impairment in the ability to either understand and or produce speech, as well as apraxia, which is characterized by impairment to perform purposeful movements, right? Getting up from the sofa and then starting to prepare a meal, yeah. Whereas maybe someone who's suffering from apraxia, they'll be kind of confused and just sit there, right? Or they know that they're feeling hungry, but they just don't know what to do next, right? To get up out of the sofa and then where did they? One, maybe not even getting off from the sofa, but if they do, then where do I go next, kind of a thing. Agnosia, an inability, even though they can see the objects clearly, right? Having a difficulty recognizing objects. Yeah, and then in time, right? In the later stages of dementia, having difficulty recognizing people. Yeah. Um, when one demonstrates the initial symptoms of dementia, yeah, it typically the usual duration of dementia until the person expires, right? um, is usually about 10 years, more or less. Yeah. It is some of the initial signs may be very mild, but if they are suffering from dementia, it's usually progressive and chronic. There are some exceptions, and we'll talk about those exceptions in a moment. Yeah. By the way, if you ever have the opportunity to do some work, either in a practicum or internship or employment, in a nursing home, I highly recommend it. One, it's because it will be an incredible learning experience about the disorders that the elderly experience, in particular with dementias. Yeah, and in a nursing home, they typically are settings where you're going to see anywhere upwards of two-thirds of the population of the people in a residence, suffering from some dementia. Yeah, but it allows you to kind of see the different stages of dementia. Yeah, and a lot of different cases and how it can manifest itself differently in different individuals. Yeah, although generally, if they are suffering, in most cases, right, there are exceptions. In most cases, it is chronic and progressive. Okay. There are disturbances in executive functioning, right? Planning, organizing, reasoning, certainly abstract thinking will start getting impaired. Um, the course I just described, okay, but it's chronic and progressive, but in some cases may be stopped or even reversed. Okay, um, if it's a dementia that's caused by some of these circumstances, if it's a function of a tumor or by seizures or some other kind of metabolic disturbance, yeah, these kinds of dementias can be treatable. Alrighty. Again, that you can stop the progression or actually reverse it. Yeah. Um, and if the dementia seems to be brought, if it seems to be brought on, right, you have a dementia, but it's not brought on. It is not brought on by Alzheimer's, but it's kind of if it's brought on, initiated by a major depression, okay, or substance abuse. Again, if you treat this depression or substance abuse, you very well will affect the progression, yeah, or halt the progression of the dementia. Okay, but the great majority of cases of dementia tend to be due to Alzheimer's disease. Okay, which we'll see in a moment. Yeah, which at least at present can't be halted or reversed. Okay, in some instances, there are some medications that seem to slow down the progression somewhat. Yeah, but still, it seems to demonstrate this 10, and maybe for some it can be slowed down to 10-15 year time period. Okay. As I mentioned, the most frequent cause of dementia is Alzheimer's disease. It can also be caused by other brain diseases like Pick's disease. It can be caused by infections or other disorders such as meningitis, might bring on dementia, as well as HIV infection and encephalitis. Okay. Now, in addition to, besides a major neurocognitive disorder, someone in the initial stages of dementia maybe can be described as suffering from mild neurocognitive disorder. Okay, which, as a general matter, quite simply is identified as mild cognitive impairment. Yeah, so the symptoms are mild or moderate, modest. Yeah, so there are concerns about the person's cognitive functioning, and these problems need to be identified either by the patient or someone who's knowledgeable, someone who's around the patient typically, or client, typically family members, coworkers, and so on. Okay. And you have the same kind of problems as mentioned earlier with major neurocognitive disorder. However, they tend to be mild or modest. Okay. So the person very well can still, at this stage, clean themselves, cook for themselves, but they're having some difficulty perhaps with bills. Um, they may be having some difficulty at work, but they can do some work tasks and so on. Yeah, they very well still recognize people, can relate with people, can participate in conversations, but they're just starting to have some difficulty remembering exactly what was discussed or with whom they may have had that discussion. Okay. Individuals with mild neurocognitive deficits usually can still function independently, yeah, in complete tasks of daily living, right? Cooking, cleaning, managing themselves physically. Um, but they just need to apply more effort, yeah, or use certain cognitive strategies to remind themselves, right? Even sometimes even labeling things like on the stove, shut off, you know, um, and it's or turn off the lights and so on. Yeah, putting little signs um, near those items. Okay, so there are ways that individuals can kind of compensate for the mild, moderate deficits that they're experiencing. Okay. Now, when they're suffering from mild neurocognitive, you know, uh, problems, it's often difficult to distinguish from normal age-related changes in cognitive abilities. Okay, and that's where a neuropsych assessment can kind of parse out exactly what is a normal part of aging and what may be the initial signs of some of a dementia. Okay. Um, to kind of flesh out dementia even further, let's just talk a little bit about Alzheimer's disease. As mentioned before, when this is the driving force behind a dementia, it's progressive and irreversible. Yeah, and it is going to be a massive health. It is already a massive healthcare phenomenon, but certainly in the next few decades, it's going to be pretty global meta healthcare issue. It already is, but even more so in the next few decades. Yeah, and for those of you who are going to pursue a career in healthcare or mental health care, the odds are you very well have some kind of this will impact your work in some fashion. Yeah. Um, Now, the risk of Alzheimer's disease does increase with age, but it is not a normal part of aging. And it's fairly prevalent. 1 out of 8 people age 65 or older suffer from Alzheimer's. And when you get to 85 or older, yeah, the latter, the older elderly, it's in 1 in 3. All righty. Now, what I'd like us to do is I'd like us to watch a video of a patient suffering from Alzheimer's, and also it's a nice demonstration not only of and it's an actual individual suffering from Alzheimer's, as well as a psychologist assessing yeah, the patient's symptoms. Yeah, so let's take a look at that. And here we go.
Doris, I just want to ask you some questions about your memory, and we'll be about 20 minutes to a half hour, okay? So I can get some idea about how you're thinking. Have you had any trouble with your memory?
No.
No, it's been pretty good, huh? Yeah. Do you know what day it is today? Monday, Tuesday, Wednesday, Thursday? I told you I was going to be annoying. Can you give me your best guess what day it is?
I'd say Thursday.
What typically I think you would do is do a short battery, and off that battery where you see deficits is to push it. You'd not go beyond 2 hours, maybe 2.5 hours. What do you notice that's a problem for you? So you want to get a read of their cognitive domains, and largely they involve attention and language, visual, spatial, memory, and executive functioning. And you want to get a sense of their baseline, where they were in their life, what their premorbid personality and intelligence is. And based on that information, along with their affective status, whether they're depressed, anxious, somaticized, and having difficulty with agitation and suspiciousness, they tend to be the 98% of the problems that you get with people. And you've not really noticed anything that's terribly different for you over the last 2 or 3 years, huh?
No.
Okay. Things are pretty good at home?
Mm-hmm.
Your mood is pretty good? You eat okay? You're feeling okay?
Yeah.
That's good. And everything is pretty cool with you and your husband, huh?
Mm-hmm.
Great. How many children do you have?
2. No.
None now. But you had how many?
Just the 2.
2. What were their names?
Beverly and Billy. They both were married.
They both were married? Where are they living now?
We don't have any children right now. We did.
Once you get an understanding of those components, you then can pretty much help the person where they're at and make a reasonable projection of what needs to be done in the next 6 months to a year with where the person is going to be. Do you get feelings about that when you do talk about them?
Mm-hmm.
You do. So right now, are you feeling a little sad?
Mm-hmm.
Okay. Thank you for telling me. Now she's down in attention, she's down in language, she's down in visual spatial, she's down in executive functioning, and her memory is atrocious. Not only her short-term memory, but she can't remember when she was married, where she grew up. She gets her kids confused, so she's impaired. So we saw that in the assessment that was given to her, and we did a light battery in the sense I wanted to get a sense about each of the domains without getting absolute numbers in all of them, because that wouldn't serve us very well. This woman is so impaired. Do you find yourself sleeping a good deal during the day?
No.
No. Do you sleep okay at night?
Mm-hmm.
You do? Okay. Are you tired during the day?
Sometimes.
Sometimes. I noticed you were kind of nodding off when we talked a few minutes ago. Did you notice that?
Yeah.
You did, huh? So you'll do that on occasion, huh? Okay. Do you do much reading or do you watch TV?
No, both of those things, yes.
You do. What's your favorite television show?
Can't think of them.
Okay.
Just turn them on and watch them.
You just turn them on and watch them. What's your address? Do you know your address at home? What is it?
It's 78
78
Curtis Street.
Curtis Street. And what town?
That's Newport.
Okay, so I'm going to mention 3 words, and you say them after me when I'm done, okay?
Mm-hmm.
Apple, penny, table.
Apple, penny, table.
Super. Can you do me a favor? Can you pull out your mathematics hat and subtract 7 from 100? It was clear that she did not need a lengthy battery, that what we were into was someone in the moderate stages of dementia.
93.
Good. Her memory is not going to be her friend. Do you remember those 3 words I just asked you to remember?
No.
Do you remember any of them? No? For example, she could not remember 3 items within 1 minute's time and could not do that over a period of time. She also had poor visual spatial skills to such an extent that she didn't quite realize that the 2 figures that she drew were different. Do they look alike to you?
Yeah.
Okay. So you did a pretty good job, huh?
No.
What's the difference?
Those are spread out better.
Yours is spread out more, huh? Okay. What are those 3 words I asked you to remember? Do you Can you tell me what they are? Maybe we could train her up to be able to do some of these things. And the question would be, at what cost? Would that really provide outcomes that are better quality of life? I think one way to think about it is sort of the sloppy clinician way, which is, look, she's at about an MMSE of 13 or 12 in that ballpark, and she's pretty mellow. Let's see if we can't push her a little bit and do things that would increase her chances of learning a little bit more. Do you remember those 3 words I just asked you to remember?
No.
You remember any of them?
No.
No? I'm going to say them again. You say them after me, okay? Apple, penny, table. You say those?
Yeah, apple, penny, table.
Good.
I was going to say apple before,
Yeah.
but
You were, it was on the tip of your tongue, huh?
yeah,
Okay. What's this right here?
that's a watch.
That's a watch. What's this right here? There are 5 million dementing people now out there, and of that, about 20 to 25% are in pretty poor shape.
That's a pencil.
That's a pencil, or is it a pencil or is it a pen? We have a moral obligation to sort of better understand that group
Can be a combination.
and to know what it is we can do to make a difference.
What's this right here?
And nobody has the manual yet, but I think we have some ideas that are not bad.
I forget.
I think it's important to look at the big picture and to see what are the strengths and the weakness, and the rehab works on the strengths to see if they can pull up the weaknesses.
Yeah.
And then you're doing exactly the right thing.
Yeah. You know, I walked into nursing homes where a person with an MMSE of 13, like our patient today, has no interest in doing anything beyond that. And so you sit back and you say, well, what's my obligation here? You know, how can I prime the pump here a little bit more without pushing her over the cliff? That gets tough. And so you bring in all the help you can there with the nursing assistants, with the family, with her, with what you know as sort of motivational interviewing for a 13 MMSE. And that takes some doing. But one thing we didn't assess real judiciously, although we do know she can read. And many people who are in that level can read fine. They can't comprehend or remember, but they can read the newspaper. And so a friendly intervention would be just read the first paragraph of the paper. You've done this all your life, and talk to John about it. What's that called? No, that is a weapon.
Yeah, it was a weapon.
What kind of a weapon?
Cannon.
Cannon. Good job. What about this one?
That's a sailboat.
Yeah. She might get stuck, in which case you'd make it simpler. So we'll look at some of these basic coloring books and maybe what's going on in this picture. And if she's tolerating that, that's the marker. And you would then continue with that and expand on that. All right. How about this one? What's that called? I very much appreciated Cohen Mansfield's stuff because she was saying, look, these are people who we don't have a clue with what's going on in their brain. It's so decompensated. But we know who they were. Okay. What's that called?
That's a candle, I think.
What other possibility could it be? And we know what they used to like. And we know if we give them things they used to like, they seem to light up and it optimizes their time. And other methods have been used similarly with these loop tapes and such, where people are listening to their son talk to them repetitively. And people seem to be able to handle that and light up. And so any given person might say, no, I don't want this, but most seem to get something out of it. We're almost done here. I want to just ask you to do something. What's my name?
I forgot.
Okay, I want you to remember my name. It's Dr. Heyer. Can you say it for me?
Dr. Heyer.
Yes. Now tell me again where you were born.
I was born in Somerville, Mass.
Somerville, Mass. What's my name?
I forgot.
Okay, what's my name?
William
My name is Heyer or Lower?
Heyer.
William Heyer. Dr. Heyer. Yes. Okay. So what's my name?
Dr. Heyer, William Heyer.
Okay.
Okay.
Just Dr. Heyer. Thank you. You're just organizing the environment to make it fit the person's skills. We need a better job of defining what the person's skills are and a better job with knowing the best environment to do that.
Okay, folks. I think that really captured quite well, dementia. Yeah. And Let me just and all the issues related to it. Yeah, besides the symptoms, how to assess spread, the larger picture about how do you treat someone, and what are some of the considerations? Yeah, not just clinically, morally, and so on. Yeah, very difficult to say the least. Problem to think about. Yeah. Okay. So moving right along, in terms of the biological theories underlying dementias and Alzheimer's, um, the current with Alzheimer's is that clearly it is a biologically driven disorder, which are characterized by the growth of a couple of things, particularly plaques, deposits of fibrous protein fragments, composed of a material called beta amyloid, which starts inhabiting, the brain. Yeah, it's if you've seen pictures of brains of after autopsies of Alzheimer's individuals, it's just a horrific thing to see. I mean, it's quite clear visually to see the plaques as they grow on the brain. Yeah, as well as other fibrillary tangles, twisted bundles of fibers of a protein called tau. Yeah, and the damage done to the brain is really apparent. Yeah, when you compare someone Alzheimer's brain to a normal brain, it's abundantly clear the damage that's done by the plaques and the neurofibrillary tangles. The course, as mentioned before, it tends to go along about a 10-year time frame. Sometimes it may stretch out to about 15, with at the end of the progression resulting in death. Um, early stages, you have some limited attentional memory problems. Then you can kind of break it up roughly into rule of thirds, right? And then about the first 3 years are mild, and the middle three tend to be more moderate, right? Requiring more assistance in everyday tasks. Um, they may have difficulty selecting appropriate clothing, uh, in particular on the continental US, right? Clothing necessary to deal with winter weather, for example. They may start having difficulty recalling addresses or names of family members, um, except for immediate family members, right? They may still retain the ability to identify immediate family members. Um, they may start making driving mistakes. And at this point, yeah, uh, having the person not drive may be the safest call. Yeah. Um, and they often make mistakes in recognizing themselves in the mirrors. Um, in the latter, during the moderate middle stage, middle latter part of it. Um, and in the middle latter part of it, they may no longer be able to speak in full sentences. It may be broken up into kind of telegraphic speech. Yeah. Um, and we also, around this stage, may see an increase in agitation. Yeah. But it varies with individuals. Some individuals don't demonstrate this, but others may very well demonstrate a certain degree of agitation, which may be a function of a decrease in impulse control, but also may just be a natural frustration with dealing with their symptoms. And in the advanced stage, they may start talking to themselves. You may see the presence of hallucinations, auditory, visual, as well as paranoid delusions. Okay, and the cognitive functioning really gets to a point in the latter 3 to 4 years where the person essentially is helpless, and they are not able to live without assistance. Yeah. Uh, so with that, a lot of the treatment, yeah. Now, as mentioned in the video, yeah, there are some psychological interventions like cognitive retraining to assist in developing uh, enhancing memory or finding other memory tricks in order to help them deal with the memory deficits. But the treatment outcome literature on cognitive retraining tends to be kind of mixed. There seems to be some mild benefits, and because of that, yeah, um, as the psychologist mentioned in the video, it's kind of a judgment call whether to proceed with that. Yeah, as you need to factor in, quality of living, yeah, for the individual. Alrighty. Um, Alrighty, so moving from neurocognitive problems into other disorders that occur uh, prior to being elderly, let's talk about depression. In general, depression and anxiety symptoms generally decrease with age. Alrighty, but there is a sharp rise. So around 65, we start seeing a decrease. Yeah, I think I may have mentioned before in a prior lecture about, interesting enough, in terms of marital satisfaction. Yeah, that those married couples, when they hit around the age of 65, marital satisfaction is often at its highest. Yeah, for reasons we don't have to revisit. I think we had discussed that earlier. So we very often see a decrease in depressive and anxiety symptoms. Yeah, part of that may be a function of some of the changes. Yeah, certainly changes like in marriages, right? The children are away, they have more income to spend on themselves, they're retired, they can travel, all that kind of stuff. Yeah, but certainly those changes, yeah, financially and situational changes certainly vary across SES. Yeah, so for middle upper income families, it may be a time of decreased stress and decreased depressive and anxiety symptoms and increased happiness and satisfaction. Yeah, but for those in low SES brackets, it may be a time of increased stress. Yeah, and anxiety about their financial stability and access to resources. Okay, there's but despite this period around the early elderly period, 65 to 75 and 75 into 85, there's a sharp rise in the rate of depression in those who are past the age of 80. Yes, and later elderly, we start seeing a really sharp increase in depression as well as suicide. Yeah. And now what characterizes aging for those who are in the latter elderly stage? Very often significant decrements in terms of physical agility, mobility. Yeah, we might see more elderly individuals who have to use walkers or be in a wheelchair and so on. Yeah. Um, Also, at about age 80, I mean, starting in even early during the early elderly period, but certainly as you progress into the 80s, yeah, um, what individuals will have to contend with will be losses of significant relationships, yeah, family members, spouses, friends, and so on, where one's social network can, depending on the family situation, can decrease significantly. Yeah. um and even in those families where they have access or live in a multi-generational family, right? Those who are elderly, the later elderly individuals will still, even in that kind of social kind of support system, yeah, will be losing the members of the family that they were closest to. Yes, spouses, siblings, and so on. Yeah. It's kind of interesting. I remember one person kind of pointing out that even aside from spouses, yeah, the people that you will know the longest in your life, yeah, are probably going to be siblings if you have siblings. Yeah. Even your spouse might not know you as long because, right, maybe you met your spouse in your 20s, right? But your siblings knew you from, when you were born, and those are probably the people you will have known the longest. Yeah, and provided if you had a happy or satisfying relationship with siblings, right, when they pass, right, those will be significant individuals, not only obviously because they're siblings, but because they will be the people you will have known the longest. Yeah. um well through Although fewer older adults suffer from major depression than do younger adults, yes, suicide is far more frequent among older adults. Yeah, as you may recall from our chart, right? Young adults, it starts increasing, but it's really in middle age where it spikes. It's particularly high. Then it starts dipping down, right? As you progress through middle age, and then even in being a young elderly person, 65 to 75, it's lower. Yeah, but then it starts spiking up again, and and then the next peak you see it will be for those in their mid 80s. Okay, when older adults experience depressive symptoms, it's likely due to an increase in somatic physical problems, okay, and physical changes, uh, Again, a decrease in terms of a sense of physical control, like walking and so on, and also a narrowing of long-term opportunities, in terms of making relationships and work and so on. Okay, and with that, that's all I have to say about disorders commonly found um, among the elderly. Okay, so that's all I have to say about chapter 14. Again, thank you so much for your the honor, the privilege of your attention. And with that, I'll see you when we talk about the last chapter, and as we talk about abnormal psychology and the law. All right, so see you in chapter 15, and take care. Bye bye.